Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Brownold, and our podcast is brought to you by TytoCare. In each episode, we sit down with healthcare leaders who are really doing the work, not just by imagining access, but by rebuilding it from the ground up. Today, we're joined by Sheila Phicil, who is a health equity strategist, systems thinker, and founder of Phicil-itate Change, which is a new innovation studio focused on building tech that actually meets patients' needs. Sheila, thank you so much for joining us today.
Thank you for having me, Joanna. This is so great. I'm so excited to be on your podcast.
I'm so excited too. We're going to jump in a bit at the deep end here, so don't panic. You've worked with so many startups and you've said 98% of them fail. So I kind of want to start there and discuss a little bit about your perspective in terms of what health systems should be looking for when they evaluate new tech solutions or partners. What red flags do you watch out for? And what kind of advice you would have for that?
Absolutely. So when I learned that statistics that 98% of digital health startups failed, I was absolutely floored, but also kind of like, okay, that makes sense now. So my background, and I come from nearly 20 years as a health systems operator, strategist, innovation leader. So I've worked in some of the top hospitals in the US, particularly in the Boston area, where I was the person on the inside making decisions around some of the technology that we were bringing in, how we implemented, and then seeing kind of the effects that it has on whatever objectives we were trying to meet, but more specifically directly on our patients and the teams that were supporting them. And a lot of times, what we ran into when you're a health system trying to solve a problem and you're looking for the right technology, the first thing is just finding the technology that fits for your
Mm-hmm.
needs, right? But when we talk about fit, that's a complex thing, right? And it's very layered. And oftentimes, when we're being approached by startups or digital health companies that have technology that they want to sell, they're pitching to some sort of bottom line, right? You're going to be able to increase your revenue or decrease your costs, or see patients faster or reduce your readmissions. But what often happens when you unpack the technology and think about, like, okay, well, how does this actually work? The first issue that we run into often is that it's really hard for patients to navigate the tool, right? Because there's like not accessibility thought of upfront into the platform, whether it's like language, engagement strategies, those kinds of things. And sometimes we're not fully thinking about the experience of the provider that's already in several systems that they have to click around and look for information. So we're adding
Mm-hmm.
steps and inefficiency that make it really difficult to say yes, right? And so when you think about bringing in a product that fits, what we really need to be thinking about is product system fit, thinking about the system of
Okay.
care that starts with the
Yeah.
patient, but also considers caregivers, right? Because patients are often not in a bubble. They usually have a family member or a paid
Mm-hmm.
caregiver that's supporting them, right? Then you think about the provider, their needs, what their objectives are, and the efficiency of their workflow. And then you have to also think about other system actors who might not be directly impacted or touching the technology, but they have to support it or enable it. And then after that, once you have those players fully thought of, then we think about payment. And oftentimes it starts at the other end. And that's why we end up with tools that don't ultimately fit.
That don't work. So people are kind of starting, or whether it's the tech developers or the health systems who are selecting them, are starting kind of thinking from the top as opposed to thinking from the bottom and what that looks like for the patient directly.
Absolutely. Absolutely.
And what kinds of digital health or AI enabled tools have you seen actually work? And especially, obviously, we're talking about access here. So, especially when it comes to reaching underserved populations. And I'm assuming that, as we know, many of those populations will have additional layers of potential difficulties or challenges when it comes to tech, when it comes to access. Are there any patterns in what's succeeding or in what's falling short?
So I can talk about my experience both kind of within the system and what I've seen now as a founder. So one experience in particular, one of my roles leading Health Equity Accelerator as a director of innovation was to help us think through how do we make it easy for us to get information about patients' social determinants of health, right? Their
Okay.
housing situation, access to healthy food, whether they have employment and have other needs, such as caregiver support, right? Now, when a patient comes into a hospital and you're asking them all these questions, well, first of all, that creates work for them. It creates work for the providers, right? Who then have to like document this information. It creates work for social workers who have to then like, okay, so you said you don't have food. Now I got to connect you to a food bank. It creates a lot of work to do good,
Yeah.
right? So we were
Yeah.
looking for a solution that could minimize the work, help us collect the information seamlessly, and
Uh-huh.
kind of embed it into the patient experience without creating much more work. It was actually when we went out into the market to try to look for that solution, we found technology that could do some of the things. Like, could you like send a text message to the patient with a link on their phone, right? Rather
Yeah.
than them having to sign into this patient portal where they have to remember a username and password and all the things.
Yeah. Yeah.
Could we make it language accessible where a patient that speaks Spanish or Portuguese or Haitian Creole can also access the
Uh-huh.
tool and conversate, right, and share information? But what I often found in talking to different technology providers, they had not even thought of those things. Is your solution even integrated into our electronic medical record so that providers can see what information is being communicated with patients? And I have to say, I kind of got lucky. I was at a conference when I heard a founder speaking on a panel who had started this
Uh-huh.
wonderful product where they solved all those things, and they were essentially using um, AI voice enabled bots with the support of social workers that would talk to the patients, get their information, and actually submit the application or any information that was needed for them to connect to the resource on the patient's behalf, and then give them alerts when it was received, which was
Wow, that's
game
amazing.
changing.
Yeah. Yeah.
And what was wonderful about this founder is he was a nurse. So he
Okay.
also had the experience of being a provider and understanding some of the bottlenecks. So we piloted this technology actually in our geriatric clinic. And the reason we chose our
Okay.
geriatric clinic is if it works with a geriatric patient, it'll work for anyone.
That's what I literally say. If my mom can do this, pretend you're talking to my mom. If my mom can do this, anyone can do it. She's gonna kill me.
Exactly, exactly. And they also had the highest need because geriatric
Mhm.
clinicians are typically under supported because it's not a practice that makes a lot of money. And they generally serve as primary care physicians, right? They're doing everything for the patient. So when we piloted it, it was so successful that the doctors are like, please don't take this away from us.
Amazing.
That's when you know you have a
Amazing.
win, right?
Yes,
Because you've
absolutely.
completely added value, you've removed friction, and you've created an experience where the provider just says, hey, call this number, they'll take care of you. And the
Mhm.
patient is delighted because their burden is reduced on their end as well, right? So, those are the kinds of solutions when you're really creating great experiences for the patient, for the family, for the provider. Those are the ones that win.
Yeah, so patient experience at the top and then kind of everything else trickles in from there. And one of the reasons I was really excited to speak with you today is because you have that kind of dual experience because you've kind of been in the health system and now you're outside the health system. So you kind of come at this from two different angles, which gives you that depth of knowledge and understanding. And I wanted to talk to you a little bit about how you've used that inside knowledge, if you like, to build your own framework because you have the seeds model for equity centered innovation. And you've kind of given us a couple of examples of products that you've found. But as you even said yourself, like you found that by accident because you happened to hear the guy speak. So part of what I'm excited to hear from you is that scaling, is that building and that launch. What does it mean to build with patients, not just for them, but together? And what does it look like in the early stages of building or deploying a solution and then scaling?
Well, I was fortunate in that my experience inside the healthcare system really started to shape my understanding of what was wrong, right? When you live in it and you see how we end up in the situations that we're in because of like systematic decisions that we're making or policies that are in place or the way that payments are made, there is a lot that contributes to the high level of unnecessary complexity in the
Hmm.
system, right? But I also
Right.
fundamentally believe every system is perfectly designed to produce the results that it gets. So if you want different results, you really do have to design differently. And so, what I learned from being inside of the health system is a lot of the decisions that are made by system actors, and I was one of them as an administrator, as a strategic consultant, as a director, we're often making those decisions in a bubble, right? Where we're looking at
Mhm.
past data, we're looking at trends, we're looking at patterns, we're looking at what worked in the past, we're benchmarking with other institutions. And honestly, we're doing the best that we can in terms of like finding those data points to help us make the decision. And then once you make a decision, of course, then it's like, okay, we have to measure the results. And, we have tools like lean methodology where you can keep iterating and making things better. But what I saw consistently got missed in that process is the people who are closest to the pain are often the
Mhm.
ones that actually have the solution. So rather than being up here an administrator in your conference room figuring out, well, how do we reduce wait times? Talk to your
Yeah.
front desk staff,
Mhm.
right? Or if
Yeah.
we're up here trying to figure out, well, how do we attract more of this particular type of patient? Talk to the doctor or the,
Speak
or
to the
the
patient.
provider that sees them,
Yeah.
right? Or talk to the
Yes.
patient and the families who are facing those problems. And for whatever reason, later in my career, when I got more confidence and I would start to bring this up, people were like, yeah, we should do that. But then weren't really sure how to do
It's also,
that,
I think once you're in
right?
that once you're stuck exactly, once you're stuck in that bubble and it's hard to sort of get yourself out of the loop where it's like the great brainstorming session where you're sitting there and you're in this
Yes,
room and you've come up with this amazing idea and then you leave the room and everyone's like, "What are you talking about? This makes no sense." It's because we spend too much time, like, hearing our own thoughts percolate.
we do. We do. I think it's the unfortunate side of building up institutions where you have layers and layers of people and committees and emails
Mhm.
and meetings. Like everything takes 5 meetings before we can make a decision. And
Yes.
again, we're doing the best that we can, but we have to also acknowledge that best isn't good enough when you have patients
Mhm.
showing up to an emergency room and waiting 8 hours with debilitating pain. It's not good enough when we're giving providers 20 minutes to see a patient and they're running hours behind and walking into the patient's room and the patient's ready to fight them, right? Because they're in pain or they're confused and they feel like they're
Yeah.
not being heard or taken care of. We've literally designed a system that underserves patients and burns out providers unnecessarily.
Yeah, absolutely. And I think that that's that balance between those two, and they're exactly the people that we should be talking about when it comes, well, that we should be
Yes.
talking to when it comes to solving these problems. And one of the things that I really like about your approach is that local design and local context, and how I guess I think we know why that's so important, but I would love to hear your take as well. But how do we design for scale? Because I mean, a lot of these ideas or these solutions work really, really well if we're speaking to a patient or 10 patients. But once we're looking at scaling and helping to support an entire health system worth of patients, how do we continue to make this a localized solution and a personalized solution?
Yes. And that's actually what I'm able to guide people through with the SEEDS framework.
Hmm.
So the SEEDS framework starts with S, systemic problem identification. The first thing we have to get right is we have to actually define the problem at the place where we kind of have fully understood the systems that lead to that issue, right? So I'll give you an example. We were trying to solve a problem of patients not showing up for their visits. So we did a
Okay.
quick survey and we talked to a couple patients and we called them on the phone. We're like, okay, what is it? Is it, do you need transportation? That the time doesn't work? Like, what's going on? And, some of the patients were like, yeah, transportation's an issue. So we decided, how about we give free Uber rides to the doctor's visits? So we ran a pilot doing that. And then patients didn't show up for the Uber ride. So had
Right.
we really
Yeah.
identified the real systemic issue? No,
Hmm.
we had not. So that's an example of like you really need to get down to the root cause of the problem. Once you do that, often what you're finding is there is a population of people that are facing huge barriers, what I call like the most complex or vulnerable patients. That's where
Hmm.
you're going to uncover the deepest problems because they're the ones that are completely unable to overcome those barriers. And what we often do in the digital health innovation startup space, we talk about your ideal customer. There's no such thing in healthcare. And if you design around your ideal customer, you're setting yourself up to fail,
Well,
right?
you're
Because
you're gonna
again,
design for your healthiest customer. Well, that's not the
exactly,
one who needs
right?
our help the
Who's
most. Yeah.
Exactly. The one who speaks the language and has a master's degree and has a personal driver that can, whatever it might be, right? But they already have systems in place that help them overcome every barrier.
Mhm.
So this is why we say then the next thing is like an equity centered design principle where you're identifying who's the patient that's having the hardest time in this system and how do we solve for them to engage. Once you do that and you're thinking through, is it a language barrier? Is it communication? Do they need additional support? How do we deliver the right kind of information at the right time for that person? And then you can move into the next steps of the process where we're thinking about how do we make sure that we're aligned with the system, the ecosystem, right? That includes the providers and we're integrating into the electronic medical record system and other things, right? And then we have to think obviously about data privacy, but I would go a step further and actually push us to think about data sovereignty. What often happens is
Okay.
we have these startups that, build up, they collect all this data from patients and then they go belly up. But what happened to all that health information or data, right? That's a
Okay.
lot of information that was collected that we could have learned from. Data sovereignty puts us in a position where patients own their data and they take their data
Mhm.
with them and they control how their data is used and they consent on how their data is used. I do think that that is the future of building good technology because it puts the control back into the hands of the patient. And then last but not least, you have to think about the last step in the C's is to think about how do you get to sustainable scaling? And this is where you have to think not just about revenue, but also what added value are you bringing into the ecosystem that embeds you and makes it so that your product and what you produce for people has a long-term value.
Right. Right. And I guess I have a couple of follow-up questions. I want to speak to you about, you mentioned integration, but I've been scribbling notes on because this is really interesting and I think we could do like a 3-hour podcast episode, but
Yes.
we don't have time for that. But in terms of, I mean, based on your experience and this is a little bit of irreverent question, I guess, because I know exactly how I feel about this topic, and I know how you feel about this topic, and I know how many of our listeners feel about this topic. But if I'm playing devil's advocate for a second, what percentage of patients is it really that fall into this bucket of these are the people we need to design for because they need the most help? And if we're talking about scale, how does that feed back into the system to make it economically viable for them to provide for those patients?
I'm so glad you asked that question because I get asked that a lot. Because what often I think there's this assumption that because the patient faces a lot of complexities, then that means we end up with a complex product. And that's not true. What we're
Hmm.
proposing is that deeply understand the barriers that the most vulnerable patients face and then build easy technical solutions that will make it so that they can overcome those barriers. So that if you have a patient, like we said, who's like our mom, right? If my mom can easily like navigate and get to where she needs to on the app, then anyone can, right?
Anyone
If a
can.
patient who's blind or deaf or, doesn't speak the language or is neurodivergent, if they can figure it out, then you design a product that will work for everyone. It's
Hmm.
kind of like the wheelchair ramp effect, right? When we really invested in infrastructure around access for people with disabilities, right? We put these wheelchair ramps on different, sidewalks and going into the airport and other
Hmm.
places, right? Because it makes it easier to roll a wheelchair. But it doesn't just serve people in wheelchairs. It serves the
Yeah.
mom with the stroller. It serves the
Yeah.
traveler with the rolling bag, right? It's the same idea, but you're building it in early on so that you're getting the highest level of engagement from the start. And it isn't engagement the name of the game. If people are not adopting and using your product, you're not going to get traction, right?
Yeah.
You're not going to
No,
get
that
that
makes a lot of
pilot.
sense. Yeah, that makes a lot of sense. You're building for that patient, but everyone can use it that way, as opposed to
Yes.
building for the ideal, in very sarcastic air quote, uh, air quotes. Thank
Yes.
you. So let's go back to our regularly scheduled questions and talk a little bit about integration, because this is something you've mentioned quite a few times. And it's something that, we see a lot where you can build the best tool that you want, but if it doesn't fit into the system, if there is no easy way for people to access it and to leverage it as part of their existing workflow, it's not going to be used. So what advice, do you have for founders or care teams to try and make that integration work as best as possible? How have you seen solutions make that work or not?
Yeah. So when we think about integration, I think obviously the immediate thing we think about is like, does your solution plug into the electronic medical record? Is
Yeah.
it easy for providers or patients to like access the interface? That is literally the foundation. What you have to think about from that point on is like, when the system fails, how do people problem solve? Who do they talk to? Do they turn to their neighbor? Do they talk to their supervisor? Do they go in and like do a search in the system? So
Hmm.
that's another workflow that you have to consider because things will fall apart. And at that failure point, if you've made it difficult for people to find the solution, it doesn't matter that it's integrated. Is it 5 clicks to get to my endpoint or is it two? And is it intuitive and clear? When I do get to where I'm trying to go, do I get exactly the information that I need, or do I have to scroll through and navigate all this other things
Yeah.
before I get exactly to what I need, right? So when we talk about integration into the workflows, yes, we want the systems to be able to talk to each other, but you also have to think about the systems that people use to answer the questions that they need to troubleshoot, problem solve. And we also
Hmm.
have to think about the people who might not directly be using the system, but are affected by it. Right.
Okay.
So, in any health system, you have providers that are using electronic medical records and they're inputting data, but you also have analysts who need access to that information to produce
Okay.
reports or to show efficacy. If it's hard for them to pull the data out of the system to be able to demonstrate like how it's working, you created a barrier for them unnecessarily, right? And that's a player most people don't think about, but the analyst that's proving that your product is doing what it's supposed to do is probably your most important champion, and you
Yeah.
haven't even
Yeah.
thought about them.
Yeah, that's really interesting. I hadn't thought about that until you just said that. But I mean, the integration, and I think it's something that we all think about as people when we're using any product, using the internet. How easy can I find this information? How easily can I use this website? And when we're looking at those patients who are already struggling for access, they're the ones who are going to fall between the cracks, right? It's not going to be me who's
Yes,
sitting here in my office at my computer, taking my time to find the information that I need. I'm going to sit here until I find it. It's going to be the people who are struggling to access that information in the first place.
exactly.
So I want to talk about a bit more about some of the work that you're doing at Facilitate Change, because you mentioned that you're about to launch your MVP, which is really exciting. So I want to hear a bit more about that. I want to hear about who you're hoping to collaborate with. You mentioned you've been so busy, which is so exciting and also so challenging, I guess. So can you tell me a little bit about that and tell people what you're working on?
Well, I'm excited to announce that our MVP is launched and live. So I'm really excited about that. So, Facilitate Change, we're innovation studio. So, the problem we're trying to solve is bringing more tools and infrastructure into the healthcare innovation space. So, some of the things that I've talked about are easier to do, right, at
Mhm.
scale. I've mentioned, if you're going to design a product, you should talk to patients, but that's actually harder to do in real life, right? First of all, like you have to ask the right questions, you have to find the patients. Once you talk to them once, the information's stale, so you have to keep talking to them. So we've designed a platform that listens to patients continuously in their native language in whatever modality works best for them, whether it's over voice, text, or using a web or app. And we are being the broker to kind of deeply understand the problem that you're trying to solve, framing the question to those patients, and we're collecting those narratives, analyzing it using AI and human experts to give you exactly the insight that unlocks that next step on your path to product system fit. Right. And so that platform launch is called Listen First. And first is spelled with a PH because, we're sticking with the PH family
The
here.
PH thing.
Yes. And so our product now is able to talk to patients. We're using voice agents in English, Spanish, Portuguese, and Mandarin. And we're right now still in that phase of like testing and refining our solution so that we can scale this up. So we're
Hmm.
looking for patients who are looking to share their story. What's important about the platform is we've designed it around a data sovereignty model. And what that means
Okay.
is patients retain control over their data. So upfront, you're telling us not just consenting, yes, you can use my data, but for how long do we have access to your data? It could be 1 month, 1 year, or as soon as you decide to change your mind. You're also telling us how you want your data to be worked with, whether it's, with a human that's using a computer, a human that's in the loop with AI, or AI only. We want to be
Okay.
transparent and give people those options up front. And the most important piece, we compensate patients not just when we're collecting their narratives, but every time we're accessing their story again to generate insights for the next user. So it becomes an asset, and patients can continuously make money from the stories and the information that they've shared, but it also puts them in a position of power as an expert. And then on the other end, for that healthcare startup, for that health system innovator, you don't have to go through all the steps of like, okay, now I have to set up a focus group. Now I have to find the
Yeah.
patients. And now I have to ask the questions. And now I have to
Hmm.
pay them for their time, right? All of
Yeah.
that is figured out for you.
So I was going to ask if I'm the health system and I'm the health startup and I want to come to you and work with you, are you putting together specific questions that you're asking the patients for me, or are you taking the information that you already have from the patients and kind of cross-checking it for the answers that I want to find?
So there's two parts. As we bring more patients onto the platform and we're collecting more narratives and insights, we will have insights that are available on the platform. At
Mhm.
this initial stage, what we're doing is we're working with startups and health system innovators to deeply understand the problem that you're trying to solve. And then we're crafting the right questions and sourcing the patients to give us answers to those questions and then presenting the insights to you in the form of a report and down the road into like an interactive like dashboard or tool that you can
Okay.
use. Yes.
Okay. But then those patients who choose for that data to potentially be available for a year, you might get another startup in 6 months that's got kind of similar questions, even if they're coming from a completely different angle, and you've already got that data.
Exactly.
I
Yes.
love it. This actually brings me back to a question I had before about the data sovereignty. So if I'm a health system
Mhm.
and ideally for me, I want to own that data. Or if I'm a digital health startup, ideally for me, I want to own that data so that a patient can't say to me halfway through whatever process it is that I'm working on, actually, I want to take my data back now. How do you balance those two needs? Obviously, it's my data, I'm the patient, but I think as consumers, we're not used to owning our data. We're used to just hitting I agree to whichever
Yes.
form comes through, which is 3 pages long and we don't read. Or, how do we balance that on the needs of both parties? And I'm just kind of thinking, sorry, this is a really long winded question, but I'm just kind of thinking, in terms of like scientific studies, for example, if I have data sovereignty and I'm part of a scientific study and I can pull my data out halfway through, that doesn't help us develop that potential health solution. How do those two needs balance?
Yes, you bring up a good point. So there's data in the context of research, and then there's data in the context of just understanding what's going on so that we can make better decisions. So this doesn't replace the data that's needed in the context of research, although I am a strong proponent that patients should still have sovereignty over their data, even in those contexts. This is really for the startup or the innovator that's trying to figure out, okay, we're going to launch this feature, but how do we know that people are even going to engage with it, right?
Mhm.
Which we
Okay.
have a whole roadmap of features that we can roll out. Which ones do we prioritize, right? You want your users helping you to make those decisions, not coming up with assumptions that you have to keep trying and testing over and over and over again. Also, from the perspective of even health systems, and I've started to say this more out loud, so I'm going to say it with my chest. We need to drain this idea of collecting all this data and hoarding data because it don't see real evidence that it drives innovation. What it drives is health systems feeling like we have these massive data sets. And we're creating these fancy dashboards telling us all this information. And still at the end of the day, where our systems are not designed to help people. So is that data really helping? Right? We don't have a data problem. we have a decision-making problem, right? So you need to ask the right questions that get you to the answers that you need to make the next best decision. And we need to get away from glorifying data. And I've been that person, right? As an administrator, where even in the project I was telling you about, where we're trying to do better in terms of social determinants of health, and we're getting all these responses from patients about, you know, what's happening with their housing and their food and their jobs. And we created this beautiful dashboard. And guess how many people use it? How many decisions it helped us make? How many times it helped us to, like, help a particular patient or population of people? Not that many times. For the amount of money and effort that went into building it, it was fancy and it looked good on a slide, and that was it. So I would go as far as challenging people, like, what has that data actually done for you, has done for patients, has done for providers? And if it's not doing it, we don't need any more data. We need better decisions.
Yeah. I think there's also such a thing as being kind of bogged down by almost too much data. Like at a certain point, we don't
Yes.
actually need more data. We
Don't
cannot
really
make
need
more
more data.
informed decisions with another X amount of data. We are already informed enough and we should be kind of making the
Yes.
decision.
We need to ask better questions, and
Mhm.
that's what's gonna get us to innovation.
And is that something that as part of the product, are you also working with those health systems slash digital health startups slash whatever to help them ask the right questions?
Yes, and it starts by we what we do is we start by unpacking what is your innovation objective. So remember, we go back to the first S in the seeds, systemic problem identification. Let's really boil it down to what problem are you solving? We start with the patient and then we move into the perspective of the provider, system actors, and payers. And we make sure we fully define the problem across the entire system. Once we
Mhm.
understand what your problem is and your objective that you're trying to fix, or whatever assumption that you need to validate, then we can go and frame the right questions. And also, we're co designing with patients. We're not just coming up with questions and then testing it on patients. We're getting patients into the process and saying, hey, we want to find out about your experience with using glucose monitors, for example. Help us to better ask this question. What kind of question would help you feel comfortable? And we refine the questions through the process until we get it right. And then we can scale it, right? So we make sure we're getting high quality responses. How many times do we like get a survey, we edit it, and then we like blast it out? And then we still are not sure, like, do people really understand the question? The best person to tell you that is the person that's answering the question,
Answering the
right?
question.
So we do that work for you. Yes.
Love it. This is great. Thank you so much for sharing. And I'm excited
Hmm.
to hopefully have you back in like a year and hear all about the results of this and how it's going. I want to quickly kind of go back to your earlier career because a lot of what you've spoken about is the basis is coming from some of the major systems that you've worked at. You've worked at Brigham, Boston Medical. Can you share maybe one lesson that you learned there that still shapes how you think about access and equity today?
Yes, there was one experience in particular, but I think it's symbolic of kind of a lot of what happens when you are, an administrator making decisions, right? An administrator, obviously, I'm not someone that's like touching patients. I'm not
Hmm.
responsible for the clinical care, but I'm setting up the infrastructure, the rules, and the resources that guide people in terms of how they do that work. And I definitely was in a position where unfortunately I made decisions that systematically excluded people from care. Right. There was a point when we had a blockbuster drug that came out for leukemia. It was crazy expensive. That's a whole nother problem we need to fix in the pharmaceutical industry. And so as a hospital, we're thinking through our bottom line, and because we cannot absorb these costs. So which patient's insurance can afford it? And a lot of people are going to be wanting to be served. So how do we pace ourselves and get the right people in and everything else? And I developed a system where we essentially created a red list of insurances that did not cover patients, a yellow list where, okay, maybe we can get a prior auth, and the greens that we knew would cover patients. And we trained the teams and the front desk and the call center and everyone else on these insurances, right? And then when we looked at the patients that were now getting into beds and receiving this treatment, I noticed a pattern. They were all a certain demographic. They were all white patients, right? So it's like, wait, that that wasn't the intent. That happened. And when we look back, or when I looked back, what I saw was like on the red list was insurances like Medicaid or others that did not provide coverage, right? And who's typically on Medicaid? Who's typically on these insurance plans that do not have adequate coverage? It's Black and brown and people that are living in low socioeconomic status, right? So I created a system that was systematically excluding people. And when I woke up and realized what I'd done, I wanted to undo it, and it was impossible to do. But what I realized in that moment, like when we talk about systems harming people, it's really people behind those systems. It's
Yeah.
people that are making decisions. It's people that are enforcing policies. And even when we realize we've made a mistake, because we're locked into this idea that, well, we, made the decision and we looked at all the facts and this is what the facts say, we still can't look at what's objectively happening in front of us and say, this isn't wrong. So we got to go back to the drawing board and figure this out. Right. But there's that lack of like humility, I think, to say, okay, that wasn't the right move. Let's go back and figure this out. Let's bring in more people to help us and navigate. I think that's the part that most frustrated me, but also has been my fire now serving as a social change futurist, as someone who's an entrepreneur, founder, that I will not replicate the harms by making poor decisions. I will make better decisions by bringing in high quality information, by bringing in people, by thinking creatively. And if it doesn't work, say it doesn't work and start over.
Thank you for sharing. That's a really hard story and I guess a hard realization. But I mean, as somebody who makes many mistakes every day, going back and realizing and being humble enough to say, I made this mistake. Now what? What's the next step here? And that's, I think, an important lesson for all of us. And obviously for you, you've taken it as you said, kind of a little bit of fire to kind of do the great work that you're doing now. And speaking of the great work that you're doing now, you've been in the healthcare industry for a long time. What are you most proud of in the work that you're doing now? What keeps you inspired?
It's definitely seeing the impact on the patients. Like when I was working in health systems, the moments that brought me the most joy were when I was able to deliver solutions that actually help patients, right?
Hmm.
When a patient came in, they were able to see their doctor, they got their problem solved, and the process felt easy and seamless, right? When we're working with patients to redesign our intake process around asking about their social and living situations, and they tell us things like, you ask the question in a way that makes me feel uncomfortable. I'd feel more comfortable if you asked it this way. And then we actually change it. More patients are responding, right? Or even now, as we're testing our product with patients and getting their feedback, we're hearing things like, you know what? I've never talked to an AI voice agent for this long, but I felt
Hmm.
like I could be honest and
Yeah.
share like the truth information because I didn't feel like I was being judged. It's that magical moment of like being human and connecting in that way, but allowing technology to help us to do it better. And I think that's that sweet spot that I live for.
I love that. That's the beauty of exactly what you're doing and hopefully what we're sharing here as well.
Yes.
Sheila, thank you so much for joining me today. I really learned a lot.
Thank you. And I appreciate the opportunity to share about what we're doing at Phicil-itate Change. And the Listen First platform is live. We're looking for patients. So if you want to join our wait list, and we're bringing in patients and paying them for their time to demo our product, we're also looking for health system innovators, startups, biopharma, medical device companies. If you fall into that trap of not really understanding what people need and how to ask those questions so that you can really get to product system fit, I encourage you to reach out. Let's walk you through the platform and see if this might be a good fit for you.
Wonderful. Thank you so much, Sheila. And we're going to share those details in the description as well. If you have enjoyed today's conversation, please be sure to follow or subscribe wherever you get your podcasts. New episodes drop every 2 weeks. Please share this episode with a colleague who's passionate about digital health, access, or rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Brownold. Thank you so much for listening, and we'll see you next time.